Yes.
We are starting the SGLT2 symposium. The first speaker is Dr. Jothydev from Trivandrum. He is the chairman of Jothydev Diabetes Research Center, Trivandrum, Kochi. Managing Trustee P. Kesavadev Trust, Vice President AIRO Kerala Chapter, conduct monthly diabetes education via YouTube channel, serve in the editor of Diabetes Journal, publish the monthly internet-based free diabetes newspaper for papers, first author Indian guidelines on vaccination, insulin pumps, is a renowned diabetologist, and may I request Dr. Jothydev to start his talk.
Harshad, if I may add, Jyoti is the technology man also of India.
Vidhan, thank you. So first of all, let me again congratulate our Benchify for another very, very successful magic, because this is a magic from our Benchify, and this is going to be the last and the biggest conference for our 2020. And thank you, Vipul, for the nice words of introduction. So let me pick up the slides. So I believe that we are a little bit early. Dr. Benchify has given me the topic, and the title is Empowering ASCVD Patient Outcomes in Type 2 Diabetes, Learnings with Glyphosides. So I know that this is going to be a repetition for many of you, and hence we have included so many new information in this lecture. So let me begin with one of the WhatsApp messages that I have received very recently. This is from a patient. So some of my patients have my WhatsApp numbers with them, and he has sent me this video. And this video had a animated representation of many organs, and it has heart in it, it has kidney in it, and this illustrates the features of a new therapy in diabetes. As empagliflozin is a new therapy for diabetes, and it also provides you with the information on how it is protecting the vital organs. And he was so excited, and I gave him this reply: congratulations, yes sir, though with some difficulty I have put you on EMPA since March 2017, because I remember that it was not easy for me to start this therapy for him. It was very difficult for me, because he's a VIP, and I took almost 20 to 25 minutes to convince them that these are a new class of therapies. And I think all of you, Dr. Harshad, our Dr. Bharat, all of you will agree that it is not probably easy to begin a new therapy, especially when a drug is fairly new in the market for these patients. And I went back to my electronic medical record and found that this was started in March of 2017. And this was his reply. This was his reply. And this is how a patient is thanking the doctor. And these are those words of gratitude. I am blessed to be consulting you. And I would say that all of you listening and participating in very important international conferences like this, you learn a lot. And the information, the knowledge you acquire should be directly translated into the prescriptions. And that is when your patients are going to express their gratitude, and that is not tomorrow or day after tomorrow, and this is for the years to come, because these are therapies which are going to bring better outcomes for years to come. So with this introduction, let me begin, but I will again have a response from his own brother, and he also messaged me that I will show you in the end of my lecture. So this is again a happy news, an exciting news for all the doctors, and the message is very clear from this busy slide. We are never late. We are never late. And this is the disease continuum in type 2 diabetes. Type 2 diabetes is not an isolated disease. And these diseases, diabetes, the heart failure, coronary artery disease, chronic kidney disease, these are all interrelated. And when you travel through the continuum of this disease. From diabetes, you have microalbuminuria, macroalbuminuria, then in between you will have a coronary artery disease, and then subsequently you will have a chronic kidney disease. And this is something which is a fact, which is happening to millions and millions of subjects diagnosed to have an endothelial dysfunction. And the opportunity here for a physician is to have an intervention at every stage of the disease. At every stage of the disease, you do have an opportunity to intervene. So you don't miss an opportunity. Even if you are late, even if you are late at this stage, still there is an opportunity with this new class of therapies. And I believe that I have to start from something known to you, because that is the basic understanding of a successful teaching, from known to unknown. And this is something known to everybody. From all those 4 classical clinical trials showing that intensive glucose control will reduce microvascular complications. But it is questionable where intensive glucose control will reduce cardiovascular disease. In fact, in some of those clinical trials such as it occurred, where the target hemoglobin A1C was as low as below 6%, it in fact increased the cardiovascular mortality. Intensive glucose lowering doesn't have any favorable effect on heart failure hospitalizations. And that is again a fact known to us for several years. And when you compare SGLT2 inhibitors with other contemporary oral therapies, apart from intensive glucose lowering, this group has got several cardiometabolic advantages in reducing the visceral fat, in reducing the blood pressure, in improving the lipids, in reducing the cardiovascular risk parameters. Over to some of those areas where you require an additional focus, and where we have a lot of information, both old and new, to collate and then apply in our patients. And this is the same empiric which we have been discussing for 5 years now. Look at the Kaplan-Meier graphs. They are separating within weeks of initiating the therapy, within weeks of starting the therapy, resulting in a phenomenal 38% reduction in the cardiovascular death. And that is when we started discussing about reducing or preventing death in diabetes. This is a video which I posted in my YouTube channel in 2015. Look at the number of views, and quite exciting. This was meant only for the doctors, and this was the excitement from the empiric outcome on a therapy in diabetes, which is capable of preventing death in diabetes. So exciting. And if you extrapolate the other areas, the CV risk or the death reduction is uniform. This is independent of the baseline cardiovascular disease. The baseline CV disease, whether it is a single vessel or a multi-vessel, or whether it is peripheral artery disease, or it is a previous heart failure or history of atrial fibrillation, the CV death risk reduction with empagliflozin is independent of baseline cardiovascular disease. And this was the reason for excitement. Whatever be the underlying basic cardiovascular disease, the benefits remain the same. And the 38%, because this number is something which all of us need to remember, and this is something which we need to discuss even with our patients. 38% reduction in the death, and this included all categories. So this was a sum of all the categories which contributed to the risk reduction. So from the simple mathematics, let me now try to simplify some of those complex numbers. And these complex numbers are so important that if you want to impress upon your patients, or when you have a conversation with your colleagues, we need to discuss these numbers. And these are the robust data from the randomized clinical trials, 21% lower risk of total myocardial infarction events, both first and recurrent events, with YEMPA against placebo. And this is the overall view of all the classical clinical trials, starting from EMPA and up to the most recent published clinical trial, and that is a CVOT with etugliflozin, the Vertus CV. There are a lot of similarities. Of course, there are dissimilarities with respect to the inclusion criteria, but if you look at the duration of follow-up, or the mean age of the subjects, or the baseline hemoglobin A1C, there are similarities. And if you look at the participants with established cardiovascular disease, that was 100% in EMPA, and it was again 100% in the trial which was published in 2020, that was Vertus CV. 100% of the subjects were having an established cardiovascular disease. And now, let me try to answer to that billion-dollar question. Are they all the same or not? Because I still remember RSSDA under the leadership of Dr. Benshibai conducting our debate. And in the IPL, we were debating on whether these are the same or not. And the answer is actually very simple. If you look at the data, let me try to answer to these questions. Answer number one to the billion-dollar question. The MACE risk outcomes. The reduction in the major adverse cardiovascular events seen with only two therapies, empagliflozin and with canagliflozin in CANVAS, and in patients without ASCVD in the Credence clinical trial, that is again with canagliflozin. And with respect to the reduction in the CV death, in reducing the cardiovascular death seen with only one drug, and this advantage was documented with only one drug, and that drug was empagliflozin in EMPA-REG outcome. And this was not replicated in any other clinical trials. And we were hoping that Vertus CV with etugliflozin will provide us with the same numbers, since the inclusion criteria was similar, the population was similar, with 100% of the patients with an established cardiovascular disease at baseline, and with a mean duration of follow-up of 3 years. But the results couldn't be replicated. The reduction in the CV death until date is documented only with one gliflozin, and that is empagliflozin. And what about the reduction in the heart failure hospitalizations? And that is the finding which is uniform across all the 4 major cardiovascular outcome trials with gliflozins. Let me review the renal data. Consistent improvements in the renal outcomes, the kidney outcomes across all the SGLT2 inhibitor studies, probably excluding one at the bottom, all the others. And if you review the dedicated kidney outcome trials, such as the Credence and the DAPA-CKD, both of them have replicated the same findings from the earlier cardiovascular outcome trials. And this is the documentation in heart failure with a reduced ejection fraction. You do have some of those dedicated clinical trials, the EMPA reduced and the DEPA-HF, again documenting a significant reduction. And this is again, this is where there is a significance. This is independent of the presence of diabetes. Whether there is diabetes or not, the benefits in reducing the risk of CV death or heart failure hospitalizations in those with heart failure with reduced ejection fraction was found to be similar across the populations. And the same finding, SGLT2 inhibitors have demonstrated clinically meaningful outcomes even in studies involving patients without type 2 diabetes. So this therapy this class of therapies could be useful, and this is empagliflozin and dapagliflozin, demonstrating the benefit in kidney outcomes involving patients even without diabetes. So I have discussed the data from the existing cardiovascular outcome trials, and now it is my duty to explore whether the same findings are replicable in routine clinical practice. And this is a routine clinical practice. There is no randomization, and this is not a controlled environment. And you might start this in any patient with type 2 diabetes. And this is EMPRISE, which has been presented at the American Diabetes Association virtual conference in the month of June of 2020. Effectiveness and safety of EMPA against a couple of gliptins in routine clinical practice. And this is again a robust population of more than 78,000 patients. Here, if you look at the difference in the inclusion criteria, because a real world scenario, you cannot compare with placebo. So we are comparing with gliptins. 28% of the patients at baseline had cardiovascular disease. And look at the results. When you compare against the classical gliptins, empagliflozin has resulted in 41% reduced risk of heart failure hospitalizations and 48% reduced risk of all-cause mortality. So the same findings which you have observed earlier in the randomized clinical trials and in older subjects, and this is the same EMPRISE, and this is a subgroup analysis of elderly patients above or equal to the age of 65 years with a mean age of 72 years, and among which 48% of the patients in each group had cardiovascular disease. So it is representing a population for both primary and secondary prevention, and this is the high-risk population, the elderly population, again demonstrating the same risk reduction. All-cause mortality down by 48%, and the broad heart failure hospitalizations reduced by 43%, and this is the modified major adverse cardiovascular events, again significantly reduced, MI and ischemic or hemorrhagic stroke. Over to the second real-world evidence, and this is from the Veterans Affairs Group, the new users of EMPA and the new users of other oral agents and the kidney outcomes. So the MAKE or major adverse kidney events were defined as EGFR decline of more than 50%, or end-stage renal disease, or all-cause mortality. So these were the endpoints. And this is the research design and the methods. Look at the results. A phenomenal 32% lower risk for MAKE, and this stands for major adverse kidney events with empagliflozin compared with other non-SGLT2 inhibitors. So in the earlier real world, I compared this with gliptins, and this is with all the other oral agents put together. And if you look at the results, the kidney benefits, who all were there? The empagliflozin therapies resulting in kidney benefits were consistent. So there was a consistency. There was no dissimilarity. There was no heterogeneity. It was consistent regardless of baseline EGFR or albuminuria. It was independent of the presence of CVD or BMI, or whether the patients were using ACI or ARB or statins or insulin or diuretics. So over 3 years, it could demonstrate 32% lower risk of MAKE. Over to the third real-world evidence, and this is the Scandinavian study involving the 3 countries, Sweden, Norway, and Denmark. And again, matched for propensity, 57 variables. And around 30 new users of SGLT2 inhibitors and 30 new users of DPP4 inhibitors. So here again, you are comparing it with one of the standard of therapies, gliptins currently. You are comparing the gliflozins. And these are the surprising, stunning results. Of course, this is expected. 58% lower risk for serious kidney events. So these are a group of therapies which are currently addressing all the cardiometabolic parameters. However, all these drugs are not the same, though they belong to the same family. And these are how the real world evidence, and especially how the randomized clinical trials have effectively revolutionized the clinical practice guidelines and recommendations. The American Diabetes Association, the European Association for the Study of Diabetes, recently the KDIGO guidelines, the RSSDI ESI guidelines, the European Society of Cardiology guidelines, all these guidelines have been rewritten. The recommendations have changed based on the new data. And this has initiated from the publication of EMPA outcome in the year 2015. And this is the most recent American Diabetes Association 2021 guidelines for patients with indicators of ASCVD, established or with high risk of ASCVD, or CKD or heart failure. Consider gliflozins or GLP-1 receptor agonists. But I say it again, and this is specifically mentioned, when you are selecting an agent, you have to select an agent which has proven the benefit in the cardiovascular outcome trials, independent of baseline hemoglobin A1C. So this is the most recent KDIGO guidelines, and this is the first time they are recommending this for diabetes and CKD. So apart from the physical activity, nutrition specific for CKD and weight loss, SGLT2 inhibitors are a first-line therapy, and you can continue even at a low eGFR, but don't initiate if the eGFR is less than 30. And the dialysis, you can stop if the patient is already on SGLT2 inhibitors. But remember, select a therapy which has proven the benefit in CKD. So let me now have the summary and then go back to the first patient. Empagliflozin has demonstrated, both in randomized clinical trials and in real world, significant risk reduction for CV events, including reduction in the mortality, all-cause mortality, heart failures, and CVD and CKD progression. And we do have now robust evidence of real world replicating the same benefits which we have observed in the randomized clinical trials. So this is the response from the brother of the patient, whom I discussed in the beginning, who was reluctant to start empagliflozin. And his brother was the one who referred him to me sometime back after a myocardial infarction. And his A1C was less than 7%. And I had to convince him that this has got nothing to do with hemoglobin A1C, but this therapy is meant for something else. And incidentally, this person, the brother, used to be a doctor, and he was a teacher for me at the medical school and working with a surgery super specialty. And this is his response. My brother feels greatly relieved that you have instituted this drug from 2017 itself, empagliflozin. And this is the greatest reward for a student from his teacher for strictly following the guideline-based therapies. And I will advise and request all of you to follow guideline-recommended therapies for diabetes whenever possible. So thank you.